Welcome to Past Medical History, a series brought to you by the BJCA in partnership with Wonder Medical. Through these conversations with the doctors who we feel have shaped modern cardiology, we hope to bring you their perspective on landmark events and their take on innovation and discovery. We stand on the shoulders of giants, and we hope their stories will interest and inspire you. I'm Nikhil Alawalia, and I'm privileged today to be joined by Professor Jane Somerville, who is widely credited with establishing the field of grown-up congenital heart disease, or GOOCH, as its own subspecialty within cardiology. She has figuratively and literally written the textbook on how to manage this complex group of patients. And for her hard work throughout her career, she was awarded the ESC Gold Medal in 2008 and the American College of Cardiology Distinguished Service Award in 2012. She continues to do life-changing work through her foundation, the Somerville Foundation, and has kindly taken time out to speak to us today. So on behalf of everyone watching, welcome Professor Somerville, and thanks so much for taking time to join us.
Thank you for asking me, I'm delighted.
So Jane, a number of our viewers will only be aware of cardiology as it's practiced today. You, however, graduated in 1955 from Guy's Hospital and went on to become the house officer to Sir Russell Brock. I was wondering if you could tell us a little bit about what cardiology was like then.
Tough. They don't have it so tough now, I must say. We had very little time off. If you were lucky, you might get an evening off once every week or so. Nobody wanted to stand in for the house surgeon to Sir Russell because it was tough. As a girl, there were no special favours to you or for you, but maybe that was all right. If you want to join a man's world, you have to behave like a man, more or less. You don't have to look like a man. But, you know, we had to work very hard. All this time off and off at 5 o'clock is a load of nonsense because you had to clock your patients and all of that. Yeah. So there are lots to tell you. Maybe it'll come out. I can't even think now, but it was fun. Really enjoyed every minute of being on the house and being a doctor and running around with a stethoscope around my neck. Great.
And you mentioned being a girl in a man's world. From what I understand, you graduated at a time when the medical school was 90% men. So did you feel that you had to outperform your peers, or was that something you were aware of?
Oh, yes, we were aware of lots of things. 9% of the medical students were girls, so different from now. And did you have to outperform? I think we always will have to outperform to ever get appointed anywhere. Actually, it's a bit easier now because they'll be short of labour if they don't appoint women. I felt as we were in a man's world, we had to sort of obey by their rules, more or less, that it wasn't the time to alter them, that we just go jollying along. I don't think you can enter, if you're a butcher and you decide to be a baker, I don't think you can use butcher's rules. That's what I felt. But nowadays, I think they're obsessed with their time off, girls being girls, and I just hope that there was no fairness. If you were a girl, you were cast out as much as they could cast you out. But, you know, we do have a few advantages. Maybe we'll come to that later.
Yeah, fine. And so I was wondering if you could tell me a bit about what it was like to work with someone like Sir Russell, because he's a mythical creature to people who are practicing today, but what was it like in...
Very demanding, and all the stories, you know, like we had doctor in the house were sort of true. You went along in a long retinue. The house officer would be at the top, but he was trailed by all these men from all these people from all over the world, and they would elbow you out if they could. And we had he had a very fierce secretary who was always getting me into trouble. He didn't like addressing women direct, so he would speak to Ross. Donald Ross was the senior reg. So he would ask Ross why the houseman didn't do this, that, or the other. Sometimes Donald would say, I don't know, sir, I don't know, I just don't know. And he'd shake his head. He was very tough, very shy, quite kind, brilliant teacher, absolutely brilliant. You never learning. So you had to put up with whatever you got. No good complaining. Yeah. Very slow operator. He used to say to Donald, "Why does my house surgeon wear earrings in my operating theatre?" "I don't know, sir." "Why has she got no shoes on?" Because one's feet got hot in those disgusting boots. Oh, and all this went on, but he wouldn't address me. You know, why does my house surgeon, this was the worst, close her eyes when I'm operating? And Donald thought I was going to answer, and I was about to say, because it's such a bloody mess, but or something like that. Donald looked at me with rather triangular eyes, so I put my head down, no answer. So, I mean, you had to put up with all that, but the girls today wouldn't understand how to put up with it. I mean, there was lots of anti-girl preached. He wasn't anti-girl, he was just shy. I can remember being in Guy's Hospital and crossing the park, which you know well, being a proper Guy's man, and Sir John Conybeare, the senior physician, arrived with his retinue, and he says at the top of his voice, I was crossing down minding my own business, "Oh, Christ, another bloody woman here." Can you imagine coming from school and hearing that? That's what you had to put up with. But I'd been to school with boys, so what the hell? I didn't care about that. I just put my turned up nose in the air further and walked past with all the tittering men. But I'd been to boys' school, so I knew what they were like.
And was it worse in surgery than in medicine, or any of those stories?
I think they were more macho in medicine. It depends what they were in surgery. They were more macho. Yes. But the surgeons also had a wandering eye, as I was soon to learn, you know. So you have some advantage that boys perhaps don't.
So you went in as the surgical house officer there.
And I was a house physician to the Department of Medicine, which was the worst job you could get on the house. And I got that by chance, turned down the first time. I got that by chance because I'd won one of those clinical gold medals. Mm-hmm. By chance again, you know, sometimes fate deals you a good one. I've been very lucky in my career. So I became house physician to the Department of Medicine, which was another nightmare.
Why was it such a nightmare?
Well, because by night we had to be resident pathologist. So all the house officers would be ringing you up, cross-match blood, do this, do that. And of course there were mistakes made. It was a nightmare. There were two of us because you weren't even, well, sometimes you were expected to be on night after night, but not entirely. So what did we know about pathology? We cross-match blood on a tile. So of course if you've been out having a drink with your boyfriend or whatever, you might make the odd mistake, as I did, and was nearly fired because I cross-matched wrongly somewhere. Can
you tell us more about that?
Oh, do I have to?
No, don't.
Well, the senior hematologist disliked women more than you can imagine, and to have them enter beloved Guy's Hospital was impossible. So I was summoned to his lair at 8 o'clock in the morning, never my favourite time, and to be asked, "What about this?" And he showed me a test tube of golden fluid. I said, whatever you know. He said, "Well, you cross-matched this last night, and this man may die." Which is, I said, "What have you got to say?" So, always was something to say. I said, "Well, sir, if someone had some training who was there cross-matching blood, it might be helpful." I said, "I've had no training to be a pathologist, and that's what I'm doing by night." So he called his head technician, and said, "Get this woman out of here." So I shall see you out of Guy's. So I thought that was my number. But anyhow, I had a Lord Protector who overheard him at lunch telling the story about this terrible woman that had been let into Guy's Hospital. It was now a dangerous house officer. So he said, I didn't hear this story till years later, he said, is it possible, Reggie, she's right? We mustn't let this happen again. So nothing happened to me. It was lucky, wasn't it? I think he was my Lord Protector through my times in Guy's.
I mean, it sounds like a constant battle.
Constant battle. Constant battle. Senior Reg, horrible. Became a consultant physician. Nearly had me out of there because with a bad diabetic who was having the first renal biopsy in Hunt's house, Miriam and John. Is it still there?
I know the building. I don't know.
In there. Anyway, it's probably King's College taken over it by now. But yeah, and he had the whole assembled hospital there to see the first renal biopsy. And one thing was necessary. The renal biopsy had to cooperate. And this one was unconscious from diabetes, having had too much insulin, was in coma. So he made a fool of me and said, I'll see you out of Guy's. Leave the building, leave immediately. Foolish house officer, we can't. It was entirely his fault. I had the paper he'd given me, so I prescribed it. Horrid man. Some people may know him, and I think he's not alive. Good. It was horrible.
So, I mean, if people are telling you they want you out and this is not for you, what keeps you going?
Oh, the challenge. What right have these creatures to tell me I'm not to do medicine? Ooh, very determined, I think. That's the resilient personality brought up in the war. Mother, the powerful person. I don't think there was a father around. I do have one, but no. Must be the personality, survival, determination. Somewhere along the line, the more people tell you can't do something, to some children and to some people, the more they say, I will, if you know you're right. So that wasn't the problem. But I do think women have special problems, but we haven't got on to that we do need a bit of assistance and a Lord Protector and. But we're not on that subject. Brock was tough, but fair, and a great teacher.
And do you think these challenges made you want it more, or did they knock away?
I wanted to be a cardiac surgeon, but when I heard Blaylock lecture on turning blue patients to pink patients, I thought that's for me, not knowing anything about anything. But I didn't realize that actually I am the clumsiest person on earth and that my hands are not connected to my head, so that I better leave cardiac surgery. There's no place for me. Also, there was a man I fancied, and it wasn't very compatible with working no evenings off. I didn't think I'd ever catch him. So that was it. So I was house surgeon for a year. Very good. Knew the anatomy of the heart backwards. Very helpful. Lots of necropsies. And I had another adventure in the necropsy department too that nearly got me fired. I don't know that the young need all these. Do they need to know? Makes me laugh even now. One of the many things is you had to go down to the coroner's court when you had a death on the table in relation, as you know. Doesn't seem to happen anymore. Nobody wants to do a necropsy. But so my the first morning I went down to the coroner's court was a lovely man called Tia, who said, "Hello, my dear. Who are you?" You know how men can be. So I told him who I was and wasn't. Anyhow, and I saw the first case of asymmetrical hypertrophy. There it was. I didn't quite understand what was going on. Anyhow, about 5 times later, there was an Evel Knievel called Keith Simpson, was doing the necropsy. Wrote a very good book. And he said, "What's the matter with this patient?" Well, I said, "I don't know, sir." "You don't know, sir? What do you mean you don't know? Did you clot the patient?" "Well, I did, but I said on this firm, there's a patient with mitral stenosis and it's not there at operation. And the next thing is there's something there that is not found by the surgeon. And then there's aortic stenosis, which isn't there. What am I to do?" So all of those adventures. And Keith Simpson reported me to the secretary superintendent, who was a genitourinary surgeon, very nice, called Doherty. And I had to go to him, but Brock intervened for me. He said, "Oh my goodness." He went. I told him, "Sir, can't come to the operation tomorrow because I've got to go." No, he said, "I'll deal with it."
Good.
adventure. I'm
Yeah.
lucky I wasn't turned out.
I mean, it sounds like that, and it sounds that very frequently there were new inventions, new discoveries, new ways of doing things happening around you. Did it feel like that?
Oh, yes. Well, we had an awful bypass machine then. It was the Lily High bubble oxygenator, which, as far as I could see, killed most people. I don't think it perfused enough blood to the head of the patients, but it was a nightmare. But it was exciting. Too many trips too many patients died. But another thing that struck me is I'm the only person asking for consent. Can you imagine? So, idiot house officer who didn't know anything asking for the consent. I mean, it should have been stopped. The things that went on, at least that's been remedied now.
Yeah.
It's too much consent now. I think you tell the patients too much.
Yeah.
But it was awful.
And so it sounds like the patients weren't very aware of what was going to happen. And I suppose to some extent the doctors also
weren't either.
Didn't know what was going on. So did you feel that there was something missing in the care that was being delivered because of that? Or did you feel like it was all good at the time?
Well, I don't know. Perhaps the house officers, they are so intelligent and they think out everything. But I didn't think I had enough to make those sort of judgments that there wasn't anything missing. I was doing my best and running around like a demented tractor. I don't think we thought like that. You just got on with it and were chronically tired, of course. I don't think I thought enough about it. I'm sure now, if you were faced with that, you'd say, well, I'm not doing the right thing. I was doing my best.
Yeah. And so, I mean, the people you've named, Donald Ross,
Great
Brock,
teachers also.
yeah. What do you think make them great teachers? Because it sounded like they weren't speaking directly to you. There was
all of them. No, Brock was a great teacher. You still remember things like never let the sun go down on undrained pus. I mean, the fact that you can't find the pus, that's another thing. But there are lots of things. And Brock was an excellent diagnostician. Perhaps not the greatest surgeon, but certainly the greatest thinker. And they were very good teachers and they were very clear thinking. Ross was a good teacher too, excellent, and a very good surgeon. Paul Wood was the greatest teacher of all because he linked the bedside physical science to physiology and what was known in science, and was an innovative thinker. That's why he was surrounded by so many people. So they were great teachers, so it stuck with you. They were the best teachers I had, and when we had some awful teachers and people sort of telling you things that you remember, like one night with Venus and the rest of your night with Mercury, if you were dealing with all that sort of stuff. That's all I remembered from one of them, physicians. But you pick out if you like to be taught, and I like to teach. So I like to teach. If I had any juniors, I would practice to see what I knew. And I always liked that, even when I was at school.
What do you mean?
Well, I would teach people if they wanted to be. And I learnt that I had to read up to teach. So even before my ward rounds, when they wouldn't tell me what cases were in the ward, because I was expected to diagnose them at the bedside and then teach. But if I knew, I'd always just check what was known before, so I could catch up my registrars. Difficult. Some of them very smart.
Yeah.
But I like to teach, and the ward rounds were very big because people want to learn. And we had to be good clinicians because we didn't have all this amazing technical aid that you have now.
Yeah. And did you feel that there was pressure on you to get it right, or did you feel you could talk to the others quite openly if you didn't know something?
I taught myself and my group that you have three answers: yes, no, and I don't know. So I was an I don't know, but I do think that my firm, when I became a consultant, expected me to know. So you can't be I don't knowing too often. But you have to know when you don't know, or you have to withdraw sometimes when you don't know what's the matter with the patient and say, look, we better come back. I'm not sure what to do. You can't tell the patient too often you're not sure what to do, but you have to tell yourself. or get help or something. And I think that's a very important lesson in life. You can't be expected to know everything, but you must know when you've got to ask for help, when you should say, I don't know, and, it's a very important lesson. But you can't do it too often in public, because otherwise people are not going to follow you. They say, oh, she never knows anything, So, yeah, I was well aware.
So who did you turn to when you didn't know, when you were a consultant, let's say?
Well, I'd go and find out who would know, or I'd ask a colleague, can you come and look at this? I don't understand. Or ask the dermatologist if someone had something, or get a good general physician, very difficult to find, if you didn't know what was the matter with the patient. So, always be prepared to ask. We don't live in a desert where we're the only person, especially in London. You can always find somebody.
And I mean, we've got a system now that is dependent on MDTs to an extent, which is good in some ways, I guess.
Oh, excellent. But the problem about we had MDTs very early. I don't know, we call them that. We used to call them meetings to look at all the patients and ask the surgeon and the radiologist and all that. I think the problem about the MDT is that nobody's responsible. And honestly, patients don't like waiting for the conference and being treated by the conference. They want their own doctor, and it's lost their own doctor. There isn't one person where the buck stops any longer. And I think that's bad. But to call in all the brains is excellent. But somebody, in the end, has got to be responsible between the patient and the doctor and the consultant. And this is what's wrong with the system now. And the patients feel it. They're always waiting for the result of the MDT. But where's my doctor? What does he think? It's not good.
So you've mentioned the scenarios when we didn't know what was going on. Can I ask, was that a part of your decision to manage these patients that were in this grey area between children with heart defects and adults?
Well, two things conditioned that decision by me to make that service, because I was interested in congenital heart disease, trained as an adult cardiologist, so you can see there was a bit of mix-up there. But it became very clear to me as a surgical house officer that there was so much abnormality in the heart. And this nonsense of talking about total correction was a dream, not a reality. So what happened to the patients became a slight obsession to me if they did leave the hospital, which wasn't all that common, but occasionally they did, and occasionally there was a good result, and occasionally wonderful things happened. So that was the first thing. The second thing is that I couldn't get on the short list at the moment I thought I was ready. I think I was ready, overcooked probably, but I couldn't get on the short list of either pediatric cardiology, which was being appointed then, or adult cardiology. I was not acceptable to either, and I was the wrong gender. So I think I applied for 13 consultant jobs. By then I was married, so I was stuck to London if I was going to not take time away. But I applied for 13 and never got on any shortlist until I applied for the heart hospital, which I think was made for me. And I went in to the House Governor's office and altered the advertisement. Can you imagine doing that now? It said, I don't know what it said, but I put it adult. I altered the title, physician for congenital heart disease, and it's very rare to have that. In other words, I could do congenital heart disease at any age. We didn't have infants in the heart hospital exceptionally, and I was an adult cardiologist anyway. So I just altered the title. I forget what it was on at, but I put physician for congenital heart disease, so there was no age bar.
And do you remember if other people applied for that? Or?
Yeah. Yes. Good people, but not as well versed as I was. But I had to. And if I hadn't invented the specialty of adolescent cardiology, in 1975 we opened an adolescent ward in the heart hospital that I'd raised the money for, so that people could come. I already was going to Great Ormond Street and their adolescents were coming on, We knew we knew there was plenty of, although they were surviving, there was plenty of need for proper cardiology, and there was this interim period.
Do you have an example of a particular patient that's in your memory that was not provided good care before your service came on?
Well, I can't say people didn't do good care, but I think that I wouldn't like to say it hasn't been good care, but there's been a problem about people who grow up with congenital heart disease, because there's been a long period where the pediatric people don't want to give up, and they operate this sort of parental view with no training to look after adults. Equally well, adult cardiology is not good at congenital heart disease and is very poor at adolescents. And, well, they don't have any training, so they're very separate now. But in that time, there were lots of examples of chaotic treatment because nobody had the thing. Nobody had the training.
How did you get the training then before that?
Well, first of all, I was trained as an adult cardiologist. Secondly, I was spending a lot of time at Great Ormond Street, since I was first assistant to Wood. And secondly, when I came into cardiology, we only saw adolescents and adults with congenital heart disease. So I had all that. I was trained in all that. And I went to Great Ormond Street with Dick Bonham Carter, who was very helpful. I had a session at Great Ormond Street that I didn't tell the Heart Hospital. I had a consultant session there, two actually, and then I gave one up to Bertie Wells, whom Dick Bonham Carter wanted to give something to. But so I always kept that all my time. I've always had a very close contact with them, and I saw all the advances and innovations, and they had excellent surgery, and they had survivors, and they were now surviving and needing adolescent adult doctors. So I got them. They came to me to look after. But then it was very difficult to get it going because of many obstructions. But I had to have a new specialty. Nobody would have me in what was available. So I thought, right, I'm going to fix you lot. I'm going to be the only one who could do this. I can remember making the decision as I drove back from Great Ormond Street to the Heart Hospital, crossing Tottenham Court Road and going up the street to get the west turning road. And I thought, the only thing to do is to form your own specialty. Nobody wants you.
Did that seem like a crazy idea? Or?
No. That's what we had to do. So we collected all these patients, and they were running around the Heart Hospital till the Heart Hospital said, yeah, we do need somebody who's dealing with it. What are we going to do with all this? So I was appointed in 1972, quite late. I'd been around a long time trying to get a consultant job, but a very good thing happened in 1968 is that the university, I was a senior lecturer to Wood, and the university decreed that all clinical senior lecturers would have consultant status. So I was half, albeit a second, albeit, as the dean of the institute said to me, you can't be on the consultant lecture schedule, Miss Aubrey Latham. Why not? Well, he said, I don't have to explain why not. You can't be. I said, well, I'm giving the lectures on and I'm a senior lecturer. He said, you can't be one of us. Nice. Can you imagine saying that to a girl now? They'd be in jail. Jolly good thing too. I said, well, I'm going to be one of you, so don't speak to me like that. Flounced out of the office.
What happened then?
Well, your time came, and time came.
What I want to understand is what goes on in someone's psychology when they keep getting faced with death and failure. How do you keep going like that?
Well, I think that was difficult. It wasn't a reason that I left cardiac surgery. I left it because I was clumsy, and as I've said already. But it is difficult to know how you can tolerate that, and some surgeons can't. But the surgeons of yesteryear are a pretty tough lot. And they believed in themselves, as I think cardiac surgeons have to. And they believed, and Brock wrote a very interesting lecture for the Canada, where he slightly analyses this problem and how they are very emotional inside, but you have to go on because you have the courage and you believe in it. And they were right, but there was an awful lot of slaughter, slaughter in the early days, the first, well, really until the mid-70s when the bypass got better, or the end, did it become possible to tolerate and to even counsel anybody at the... And then there's another problem. There are good surgeons and great surgeons, but when a surgeon talks about results, he doesn't talk about his own. He talks about somebody else's. So he'll take the best. The mortality for total repair of fallows tetralogy is a common one. And he'll quote Aldo Castaneda's from Boston, or somebody from Birmingham, or somebody from... This is wrong, and they're still doing it all the time. I don't approve of that.
And so I want to understand how in this environment someone can then think, let's try just transplanting the heart.
Well, I think in this environment, the next stage was obviously transplant. If you've got a heart that's turned into stone and a young person and they're still alive, that is the obvious thing to go for next. I mean, and so they were talking about it, and actually Donald Longmore organised the first transplant in this country with his friends and colleagues around. And I think it's the obvious thing to do, and it saved a lot of lives. But of course it was very experimental, but what's better than dying? What's worse than finishing everything? You're trying, and that's the one thing about surgeons. They do have the courage. I think not only the surgeons have the courage with other people's lives, but I think the poor patient has courage too, but he doesn't know. So they went on. I think it's understandable. Whether it's justifiable is not my brief today.
Yeah. And so the first one, was that something that was long and thought out, or?
Not long and thought out. They were waiting. I think Donald Ross was waiting to do it, and he hadn't done experimental. There's a lot of experimental work going on, and there's no doubt Chris Barnard pinched Norman Shumway's ideas, but Norman Shumway, characteristically good American fashion, was doing cows and I think dogs, cows anyway, and dogs. I'm not quite sure what, but he showed Barnard, who'd thought it out. Barnard was a classmate of Donald Ross's, so it wasn't surprising that there was a lot of talk there. I think they were waiting to do it, but there was a lot to wait for. There was waiting for a donor to be right, and there was waiting for a patient, and then there was waiting for a match. The Heart Hospital was always ready. It was a great place for innovation, and Donald was very intelligent, so he was ready to do it. And Donald Longmore had thought it out in a sort of way, and he really organised it. Unfortunately, he had so much talk. He talked over the switchboard. So, of course, you can imagine the telephone operator staying on for that night, told everybody. So we had the press outside, which wasn't very good. Taught the profession. Our profession was awful to us. They didn't approve at all, the people around. What do they think they're doing? And, you can't do that operation. Perhaps your greatest critics when you have innovations are your colleagues. Not your colleagues in the hospital, your colleagues outside. Terrible criticism from Great Ormond Street when we switched the first transposition in the Heart Hospital. Because they had a good operation. Terrible criticism from your colleagues. And I think Lillihei, who invented the first bypass, had awful criticism from the senior surgical colleagues. In fact, Dwight Harkin said, "How can you do an operation that might have a 200% mortality?" And so it's got to stop when they did the first bypass, which was the father or someone transfusing the child, not a machine. And that's why Lillihei invented the disgusting bubble oxygenator, because the surgeons of America said, no more of that stuff. Innovation is very troubled by envy and also sensible criticism. All innovations have been. Donald was very criticised for putting in a valve, and what's that? It's all going to wrinkle. Awful. You've got to have surgeons of yesteryear, and I think now have to have the courage of their convictions.
Did you get that sort of criticism when you were establishing your adolescent unit?
Well, no, I don't think so. I got criticism from the. I've always had a lot of criticism. Maybe I invite it. Probably yes, but I mean I can't be bothered like that. I was too resilient. You know, if you've been through St. Guy's Hospital, as Brock used to call it, St. Guy's Hospital, and you put up with all that male carry on, we're the greatest, and women, you can, and you've been to boys' school, they're no different when they grow up. Boys are very naughty, but it's only very naughty, very necessary, but very naughty. So, you know, I don't know. It's all part of the thing. Yes, probably a criticism. And sometimes the criticism of oneself, one has to learn, is correct. I mean, my late husband, who was very everything that's wonderful, used to say, if only you were more prudent. Well, I said, I'm not. It's too late. No point in that. You know, you have to have your courage of your convictions. But I think he was, I think a lot of things, but I'm sure there was plenty of criticism. There always has been.
Yeah. I want to now come to this idea and the experiences you had as a woman in cardiology at this time. And you have gone on to achieve so much, but also had a large family with 5 children. Four. Sorry, a large family with 4 children. I mean, did you have any, how did you manage that?
Well, I think I was very lucky, and I say to the girls of today, be careful who your partner is. Be careful in the choice of partner, because we choose our partners at a time where we're probably not very perceptive as to what we want and all that goes with it. But anyway, there are lots of issues about that. I had a good husband who didn't want me ministering to him too much, you know. And he had enough money, because he was a consultant who worked hard, so that I had a nanny and a housekeeper. Having decided I wasn't going to do any of that domestic stuff, and he was quite happy with that, I also made it clear before marriage that I couldn't, I had to do medicine. I had stars in my eyes for that. I wasn't going to iron any shirts or anything like that, and didn't. I did iron a shirt once, it was a disaster, and he got a iron burn in his favourite shirt, so that was that. They went to the laundry or whatever after. So you have to have time, and we have our great enemy is fatigue. Women get much more tired. I think men are more resilient in that respect. And one does get very tired and emotional and all that stuff, but you have to put up with a lot of criticism. What's that? May make you better. And it's very hurtful sometimes. Very hurtful when you don't get positions, very hurtful when you don't get appointed, or perhaps you want a decoration you don't get. Oh, it happens all the time. And I've even been subject to criticism, comment, rude, since I retired. I'm no threat to anybody, but I think I was a bit of a threat because I was quite mouthy. That's not a good thing to be. So what would I say to the women today? Well, it's not for me to advise, don't follow me, but you have to put up with a lot. I think that the women today do have some fault, but in that there's too much going home at 5 o'clock, there's too much time off. You've got to be better than the boys, so you're going to have to be there to do that. But it's all part of the junior staff. You've just got to be better. And I think also it's very useful if you can have some sort of Lord Protector about, who I had 2, one in Guy's, who obviously was protecting me for whatever reason, but he was influential. And secondly, once I married a more mature husband who was much respected, at least the naughty boys couldn't get through the front door, so to speak. They could all meet in the bar and stop progress, which they managed perfectly well, but maybe I asked for some of it. We women aren't all wonderful all the time, and I also think the problem of us having our pregnancies, you can have a department. And if all the women go off at once, you won't have a department. So we do rather take a lot of time over our pregnancies, and we've been given a lot of gifts, which is fine. But it's very difficult to run an active department if half of your staff have gone, because they have a right. And we're rather keen on our rights now, which I think we have to think about other people's rights, like a department, to stay alive. And very often with the women having their children a bit later, they want another one very quickly, so they're really off for effectively a rather long time. Very difficult to run a department. I'm not saying you shouldn't, of course not, because what am I to say, having had 4?
Yeah. And it sounds like when you were a junior trainee, people criticised you to your face and didn't hide the fact that they didn't approve of you being a woman. Do you think things got better as you moved up the ladder, or do you think it just went silent?
By the way, this is a very sexist country. Don't have any illusions about that. They can be politically correct, but they're meeting in the bar, getting all the rest, What did you ask me? Do I think? Well, they didn't always criticise you to your face. That was one of the problems. They're easy to manage if they criticise you to your face. Boys don't generally do that. Girls will, but boys won't. It's all, political correctness now. So I don't think you know half of the criticism that goes on. So I wouldn't like to get into that one. But it's tricky. But there are faults on both sides, I do have to say. How did I manage luck, resilient personality, a good husband that put up with a lot of carry-on? And I think those 3 things. I had a good memory too. That helped. One could remember the answer even if you didn't understand it. That's always been very useful. I remember my colleague at one of these MDTs. They were sort of meetings with all the senior staff present in the heart hospital. And my colleague Edgar Sutton, who I rather liked, they were talking about a case of something or other. It doesn't matter. And I said, I don't think it's like that. I think it's something else. They were all presenting me. I think they were talking about Wolf Parkinson White or something I didn't really know much about. And I was right and the others were wrong. That's not the point of the story. And Edgar Sutton said to the assembled company, "Oh, don't take any notice. She just works by instinct, not by knowledge." Well, I was a bit taken aback, so I think that's the time I didn't answer back. But I thought, what's my instinct worse than your lack of knowledge? I think I mumbled something rude, but I was quite hurt by that. Probably was instinct now I come to think of it. One has to put up with things, and it's no good getting huffy about those things. But I remember that as an incident which was hurtful. Probably damaging too, with all the senior staff. And anyhow, you can't be worrying about those things as soon as you get home, if you have a good home and so forth. It was the amount of work was rather troublesome. But with all that help, I suppose, I wasn't domestic.
So, Professor Somerville, I can't not ask you about the Junior Cardiac Club. When I was researching your life, I understand that yourself and your husband were instrumental in the establishment of it?
Oh, not me. No, not me. He was. I think they did it. I don't know when the first was. Was it the first meeting of the JCC? He and Lawson MacDonald, and there were 2 or 3 of them, and they used to meet in a cafe, which was a sort of tea cafe, opposite the entrance of the RSM now. I had nothing to do with it, but I think it's in his diaries, and the exact formation could be found out if wanted to know. They formed it because they felt that they wanted somewhere to speak about all these innovations and what was going on in the various hospitals. So I think it was London-based, but anybody could go who was a member of the junior staff. And it grew, and it was the place to cut your teeth, to give your first paper, either that or the Junior Cardiac Society. I can remember speaking, I think we met in the Middlesex, being invited to talk about common AV canal or something. And surgical residents could go. And it was a very live forum, and we might or might not have dinner. It was fun. But it was all very well established by the time I was into cardiology.
And was it quite formal, or was it?
No, not formal at all. The Cardiac Society was formal, and when you got in, you were called by your surnames, because that's what boys did. And I said, I'm not going to be called by my surname. They might think I'm Walter. My name's Jane, and I'm not going to be called by Somerville. So that stopped that for the time. So first names came in, but no, it was very informal, lots of fun. You met your colleagues in Arts and Middlesex and wherever.
So was it a supportive network as well, or education?
No, it was a forum to hear what was going on. It wasn't supportive, it didn't do anything for you. Probably the opposite if we did, but no. But you could see what was going on and you could hear, and it was a sort of fun-based meeting once a month. Actually, we met once a month, and you could become when you became a member. Yeah, it was fun, and to have a president like you, not quite as busy as you, but they got on with whatever. It wasn't as big as it is now, but it formed in that cafe. I think it was called the Bay Tree Cafe.
I think it's a pub now.
Or else it's a men's shop. It's just opposite the side entrance. Yeah, it was there. And I remember Walter taking me to tea there. And I wasn't yet a medical student. I knew him because he was living in our road, taking out the girl next door. That's how I first met him. And he said, one day, when you're old enough and wise enough, I will take you there. That was the RSM. Oh, bully for you, but anyway. Yeah.
Great. I mean, we have almost 1,400 members now.
It's wonderful.
Yeah. What advice would you give to a cardiologist in training who wants to try and do something that they think may be too much or a bit too innovative or something that they're anxious about?
I can't answer that because you've got all this bureaucracy to get by. I think do it if you believe in it and research it well. But I would beg you all, juniors, I would beg you all, do keep your clinical skills. I was taught clinical medicine very well in Guy's Hospital. Very well we were trained. I don't know how you're trained, but half the juniors I was meeting, say, up to 10 years ago, were a disaster. They couldn't diagnose a fig from a banana. They were so unimaginative and unworking. But if you came into medicine to do medicine for patients, please keep your clinical skills. Patients like talking to the doctor, not for too long, I would think, but please keep them and be able to examine. The texts do break periodically, and then you're stuck because you can't make a diagnosis. Keep them if you want to be a doctor. If you don't want to be a doctor, that's all right. If you want to be a radiologist or a echocardiographer or whatever, but if you want to do medicine, speak to patients and like patients, you've got to keep your clinical skills. Very poor clinical skills are available now. One
thing that you did that I think is really interesting was you spent a lot of your formative years in the operating theatre and you would go to necropsies and see the anatomy. Do you think that was...
I think it was the most helpful thing I did, was being a house officer for 6 months. Not only do you begin to understand surgeons, which after all we needed to, they were our main therapy, they're not now, but also one saw anatomy. And that's very important to have a living thing in front of you as to what that heart is doing. It made a huge difference to me. And I think 3 to 6 months with the surgeons or the interventionists as students or in training wouldn't hurt you, even if you don't want to do either. I think it's very important.
And I guess seeing the pathology, like the asymmetrical septal hypertrophy, stays with you.
Oh, yes, it does. Honestly, it does. Well, there aren't necropsies done now, which I think is one of the mistakes. I think they'll have to go back to having the pathology, because you don't know if your interpretation of imaging is correct. They're blah, blah, blah. It's a blah, blah, blah. It's a there. They don't know if it's correct or not. You don't know if you're right. And they're not necropsies done now. It's very bad. Yeah. Even the coroner doesn't seem to want them very much. Very bad. You need the correction factor.
Yeah, that feedback.
Yeah.
Fine. And now looking forwards, where do you see the future of cardiology going?
Well, I imagine more and more technology. Valves will be made so they can be replaced. Rhythm business will get better because it's very techy. I think if you're not careful, you'll give up being doctors, which is sad, because cardiology is still part of general medicine and very important, and people have brains and feelings, so I hope you won't give up that. I think most things in cardiology will be solved. Prevention will become much more active, but you'll still have cardiac cases, and plenty of them. Population will get older, the valves will get calcified. We need something to stop calcification. That will happen. Genetics will play a bigger part in both therapy and prevention. But I'm telling you, you're not going to have a future unless you keep your active-minded junior staff and deal with my whistleblowing.
And what about particularly for congenital heart disease? What do you think the future has?
Well, I think the future for congenital heart disease is mainly prevention, mainly getting better surgery earlier, or better management earlier, it may be intervention. The intervention may be surgical or technical catheter. I think there'll be more and more of that. Fortunately, pediatric cardiology still requires you to be a clinician. It's no good. You need to look at the patient. It's no good asking the machine to tell you whether it's ill or not yet. Maybe that'll happen. But I think prevention, intervention, earlier diagnosis, possibly more fetal. I don't know. Possibly more fetal, depends what the country can afford.
Professor Somerville, I'd be keen to know what you're doing now. What gets you?
Well, I'm not licensed to kill anymore, so to speak, because it was all too much. And I think there comes a time where, it doesn't stop patients consulting you all the time. I have a principal interest and a principal enthusiasm to do one thing before I leave the planet, if I'm able, and that's to help the medical whistleblowers. I think unless something is done, unless these trusts are drawn in and controlled, it's going to be awful, and young people will leave the profession. They won't want to come and work in half these trusts. They're so appalling. The management of whistleblowers, young doctors in training, is absolutely appalling by many trusts. They're unjust, they victimize, they harass, and they bully. And unless this is stopped at very high level, where I think it's been licensed, I think our profession will not grow and will not be respectful and will not be successful. It is absolutely appalling, and it starts at high level with CEOs, not in all trusts, but in many. I think at Department of Health, these officers put everything under these senior officers, many of them, just put it under the carpet. And the poor young person does not have the money to have the best lawyer, to have the best advice, little or no help from the BMA. Appalling. Little or if it's going to be expensive from the MDU, they start, or the MPA. Little or no, even the judiciary seems to be corrupted, as do the lawyers in this matter. They're bought by these trusts who have endless amounts of taxpayers' money to spend getting rid of a junior who probably has not done anything more than point out that it's unsafe in the intensive care. And they will be punished for that. So none of you are going to do it. It's appalling. I hope to help those people, but it's very difficult.
Okay. Who do you think needs to lead this change then?
Well, the problem is that the trusts don't have to report to anybody, so they can spend, as they did in the unfortunate Chris Day, I think £750,000. He couldn't have money to do that. So somebody's got to discipline the trusts. Somebody has got to say whistleblowers must be judged independently, not by people the trust. There's corrupt tribunals. I could name it, but I don't want to. I have the courage to name corrupt tribunals led by corrupt people who are half in business, half doing this tribunal interrogation. Appalling. There's a young doctor, female, has got all the characteristics to be bullied. Female, small, Asian. This is in the public, I said this. Are we surprised she got bullied? They finally got rid of her with no grounds at all. What were the grounds for getting rid of her? Not fit for purpose. What is not fit for purpose? We can't get it defined. It's usually a thing in law which applies to instruments not fit for the purpose, not to humans. We cannot get it defined. She's lost her job. Consultant. So unfair. But there are many more. So you young people, you have to have somewhere where you can report it that's not in the trust, because they are not suitable to deal with it. Not all the trusts, but many. I think it's appalling, and you have to fight it. You will have to come and fight it. You will have to stand by your colleagues, but you're frightened of losing your job. One the other day lost his number. He was in training. Lost his number. They managed to get rid of it. I mean, if you've got that sort of thing going on, we are not going to keep a good standard of junior doctor to train as good consultant. That's what I would like to help, because you're all worth it.
Great. I mean, all the best with that, and a really important cause. Once again, that's something I just want to say thank you on behalf of everyone at the BJCA for giving up your time and sharing all your wisdom with us. Thank you very much.
Not wisdom, but I've loved it. Thank you.